The burning platform in healthcare is that the healthcare system really is not working. In fact, to even call it a system does an injustice to the word system. In the US, we spend perhaps 50% more per capita than anyone else in the world, and currently we have worse outcomes. So this is not a good situation where we're spending more than $3 trillion a year, 18% of our gross domestic product, in an industry that is basically sick. This is work I'm doing in collaboration with my colleague and friend, Michael Porter, at Harvard Business School. And Michael's a professor of strategy and in fact founded the field. And he got interested in healthcare 10 to 15 years ago because he wondered, how do you have a system like this sustain itself, in such an inefficient way? As he sorted through it, he realized that the fundamentals for healthy competition, which ultimately is what drives value to consumers, does not exist in healthcare. That we don't even agree on what the goal of the system is. And so Michael has proposed, and I fully agree, that the basis for organizing the healthcare sector is around value. And we have a very specific definition of value, is that for each medical condition, how do we improve the outcomes that are delivered and experienced by the patient, and how do we lower the cost of delivering those outcomes? Which doesn't seem revolutionary, but it is revolutionary because no one has defined the problem in the solution in that way. They've been all around this thing. How do we use checklists? How do we use lean and process improvement? No one's just said, how do we deliver better outcomes to patients and lower the cost of doing that? So you think about a $3 trillion a year industry in the US that doesn't know what its outcomes are and doesn't measure its cost. That explains a lot about the system that we have. And I got involved because I have developed a technology of how to measure costs. And Michael's developed an approach for how to measure outcomes. And then there's a third part, is when you have outcome measurements and you have cost measurements, you can reimburse providers in a very different way. And right now, providers are reimbursed in the US mostly by fee for service, and that rewards volume of stuff, but not value, not good outcomes, because the fees are independent of what outcomes get produced. And in fact, if you don't do a very good job and the patient has to come back for more work, you get more revenues. So that's not a very good way of paying for healthcare. So we're an advocates of an approach that's beginning to come in called bundled payment reimbursement, where you make a single payment to cover the treatment for an entire medical condition. But we are actually doing it with our flavor, which is make the payment contingent on delivering good outcomes, which seems normal, because if you buy a car and it doesn't work, you return it because it doesn't work. So it's every other industry, that's straightforward. In healthcare, this is revolutionary. So my role in this agenda, primarily at this stage, is the costing element. And what I found, and does exist, is that costs are not measured well in healthcare at the specific medical condition level. I mean, obviously, hospitals know how much they're spending. They can trace some of the spending to various clinical departments like orthopedics and cancer care, neurosurgery, but they can't take the cost at that department level and drive it down to the patient level, treating a patient for a clinical condition. Now, I've helped to develop an approach called time-driven activity-based costing, which enables that assignment of expenses to be done well at the patient level, because it just consists of really two estimates. And one of them is to understand the clinical pathway that is used to treat a patient with a medical condition. And what actually happens from the time they show up with a complaint until you diagnose it, treat it, do the surgery, the recovery, and then the therapy and release them. What are all the clinical and administrative processes that are performed to get the patient through that entire cycle of care? And when we do that, we try to find out at each process step who's doing it. And we can actually calculate how many minutes per year that person or piece of equipment is available for patient work. that typically comes out to be 90 or 100,000 minutes a year. And you divide their annual expenses by their capacity, which is really what that is, you get a cost per minute for every single individual. And what's really fascinating about healthcare is the variation in the cost rates. And so we have the MDs, whose cost rates could be somewhere between $3.50 to $6 or $8 a minute. That would be typical rates. But you have a nurse, might be $1 or $1.50 a minute, and you have clinical assistants or scribes or receptionists who are around 50 or 60 cents a minute. So you get this 10 or 12 to 1 variation between the least highly and the most highly paid person, which is really interesting because it says even if everybody's busy all the time and they're doing work, if you have a $5 a minute person doing something that an 80 cent a minute person could do equally well or slightly less efficiently, that's an inefficient use of the resources. And so there's an expression in medical care called have people work at the top of their license. But they never see the rationale or the economics behind it until you get to this costing procedure. So a combination of then we take the process times for each person multiplied by their cost rate, the cost per minute, and that tells you the cost of that person at that process step, and we just add it up across all the process steps over the whole cycle of care, and that tells you the total cost. This is not quantum mechanics or genomic sequencing, it's really simple. What makes it difficult is just there are so many process steps. So there Michael and I are sitting there at the Harvard Business School 4 or 5 years ago, and we realized, okay, this looks like this could work, but how do we get people other than the two of us to realize that this really could work in practice? There's a lot of good theories that don't work in practice. And I said, well, the only way we're going to do this is to test it in practice, and so we have to find pilot sites that are willing to try this out, because we think we'll be able to create the change by demonstrating that it works. And we want to work with leading providers, who are already excellent, and they want to be better. And they also want to prepare for the new environment where there'll be fewer resources available to pay for health care. And so the ones that are proactive and thinking ahead, that they realize that this very forgiving fee-for-service environment will phase out over the next 5 years. And they want to be ahead of the curve and see what can replace them. So currently we're working with at least 24 organizations, and they're really distinguished organizations, leaders, the Boston-based hospitals and Mayo Clinic and Cleveland Clinic. And then about 6 or 8 months ago, I got contacted by Dr. Vivian Lee here at the University of Utah Health Center. And I think Dr. Lee is a great, visionary leader, and those are the kinds of people I like working with. And so in January, I and my team came out here, we presented the ideas, and we formed up 5 teams to work on applying the time-driven ABC in 3 clinical areas and 2 support areas. And we have the benefit that Dr. Lee had already put into motion with some terrific staff here, an emerging system called value-driven outcomes. And so we're getting outcome measurements very well at the clinical level, as well as starting to trace costs to the clinical level as well. And we had to just refine the costing module within that, and to build upon the value-driven outcomes approach that was being implemented. It's been a great place to collaborate. We have the opportunity, UUHC has the opportunity, maybe with some of our assistants, to really be one of the national leaders in implementing this value-based healthcare delivery approach. And so, if we can use this as a shining light, the example that this really can be done, and it can deliver major improvements, and patients are better off, and we're doing this at lower cost, people will see that this is really a successful way for transforming the way we deliver healthcare in the United States. And there's a lot of skepticism in healthcare. They'll tell you 200 reasons why any innovation approach won't work. And my role is to show it can work.